All right, let's get started. Hi, everybody. My name is Michael Durham. My pronouns are he, him, his, and I work for the National Healthcare for the Homeless Council. And you are here for Housing Insecurity and Health Centers, the case for screening and beyond. Just want to acknowledge that this webinar is funded by HRSA. We're grateful for their support. Of course, what we say does not necessarily represent their views. So as I said, I'm Michael, and it's been such a pleasure to prepare for this webinar with my new best friends, Arlene from New Jersey and Trisha from North Carolina. We're going to hear from them a little bit later on, and so I'll let them introduce themselves at that point. So just a quick word about who we are. We're the National Healthcare for the Homeless Council. If you work for a health center or a primary care association, you probably know that we are one of 21 NTAPs, as we're called, National Training and Technical Assistance Partners, funded by HRSA to provide training and TA to all health centers, not just healthcare for the homeless. And we have kind of a new mission statement that I love to include in everything that we do here. So grounded in human rights and social justice, the National Healthcare for the Homeless Council's mission is to build an equitable, high-quality healthcare system through training, research, and advocacy in the movement to end homelessness. So we think of ourselves as sort of the healthcare arm in the movement to end homelessness. So here is the plan for today. We're going to do two quick polls here in just a second so that we can get a sense of who's here and then a sense of who is doing a screening for housing status. I'm going to get into a little bit the federal definitions of homelessness so that we all are on the same page about that. I'm not going to go too deep into some of the data on the rise of homelessness and the effects on health outcomes, but we'll get into that a little bit. I'm going to define the HCH gap, which is sort of a term that I've coined over the last year. And I'll try to get out of the way as quickly as possible so that we can get to celebrating two health centers on our panel today to talk about how they've been able to serve people experiencing homelessness without healthcare for the homeless designation. And then we've got a new paper I want to highlight. I'm going to leave you with 9 concrete actions everybody can take to address homelessness within your health centers, and then show you a bunch of resources. And the remaining time we'll have for discussion. Sound like a plan? All right, so here's the first poll. My friend Brandon is going to pull up for us. We want to know what kind of organization you're with. So the first 2 options are health center options. I want to know first, are you a healthcare for the homeless grantee? And if not, are you some other kind of health center that doesn't get healthcare for the homeless designation? And the third choice is either a PCA, an HCCN, or an NTAP. Or you could be something else. And I know that our audience is diverse and wide, and you could be working in homeless services, HUD-funded programs, national advocacy organizations. So I encourage you to tell us in the chat box. To leave that open for another moment. Great. Go ahead and close that. It looks like slight majority of folks are neither health centers nor PCAs. Just a couple of healthcare for the homeless programs, a few health centers that don't have H designation, and then a few PCA and TAP friends. So I wanted to acknowledge that we as an organization, our primary audience is the healthcare for the homeless programs, but really the audience for this webinar is everybody else. So that's appropriate here. If we can go to the next poll here, we're just going to ask, and this is really only applicable for the health center folks in the audience here, but tell us a little bit about your screening for housing insecurity. So your first options are all patients at all sites, not universally, but yes, or your third choice being case-by-case basis or not at all. Just a few more seconds on that. And thanks to everybody who's saying hi in the chat box. Great. Brandon, if you want to close that and maybe broadcast the results for folks. So it looks like 38% of you, the plurality, are screening all patients at all sites, and then a mix of the rest. Great. Well, let's get into it. I want to talk first to you about the definition of homelessness. Now, first, this is a definition from Health and Human Services specifically. And those of you who are not working in the health center space, I see there's housing advocates, HIV advocates represented here, and you are welcome. Some of you may know that the Health and Human Services definition of homelessness is broader than some others. So I am going to read this word for word, but I want to emphasize the things that I think really are important to take away here. A homeless individual is defined in Section 330 as an individual who lacks housing, without regard to whether the individual is a member of a family, including an individual whose primary residence during the night is a supervised public or private facility, so a shelter that provides temporary living accommodations, and an individual who is a resident in transitional housing. A homeless person is an individual without permanent housing, who may live on the streets in a shelter, mission, SRO, abandoned building or vehicle, or any other unstable or non-permanent situation. An individual may be considered homeless if that person is doubled up, a term that refers to a situation where individuals are unable to maintain their housing situation and are forced to stay with a series of friends and our extended family members. In addition, previously homeless individuals who are to be released from a prison or hospital may be considered homeless if they don't have a stable housing situation to which they can return. A recognition of the instability of an individual's living arrangements is critical to the definition of homelessness. So this is important for a couple of reasons. One, I want to point out that nowhere in this definition do you see anything about addiction or mental illness or hygiene or behavior. Everything here has to do with a housing situation. So that's the main takeaway here. I also want to point out that homeless and housing instability are basically interchangeable from the Health and Human Services perspective. So let's bear that in mind as we're talking about homelessness and the crisis of housing insecurity in this country going forward. This is going to be a little bit clunky, but I'm going to stop sharing my screen and switch over to a different screen to share with you, because we have a new infographic. And Trisha, nod if you can see this, because you're my barometer, you and Arlene. So we recently created this here at the council, just exploring how to depict all the different things that constitute homelessness within that definition I just went through with you. And I hope that this can be something that is useful for your health centers or your PCAs or wherever you work. So here, if you scroll down, we just kind of identified the different shelter arrangements that constitute homelessness. And I just went through all that long definition, so I won't read through each one of these. And then here we've identified those that were in that previous definition that are considered homeless for Health and Human Services, but not literally homeless for HUD. And that matters for a couple of reasons, because it's important for healthcare providers to know what services your clients may be eligible for that aren't provided by your own organization. And just knowing that there are different priorities with these different federal departments that are serving the same people. So we've kind of identified the key takeaways here. One being that the duration of homelessness is irrelevant for health centers, but it has everything to do with what kinds of services that folks may be eligible through HUD and other departments. That HHS's definition is broader. That healthcare providers, we have such an important role in helping folks get on different lists and determining their medical vulnerability and things like that. And then probably for me, the biggest takeaway here, just that many people who would fit into this definition of homeless do not consider themselves to be homeless. And that's either because they won't disclose it to you for fear of stigma or discrimination, or they just don't know that they are homeless in the first place. So I'm going to stop sharing and switch back over to my PowerPoint here. That wasn't as clunky as I thought it might be. Look, we're already back on track. So I want to show you just a few figures here. On the HUD side, Housing and Urban Development, which is largely considered the primary federal department responsible for ending homelessness, because indeed homelessness is a housing situation. And so the primary measurement that HUD uses is called the PIT count, point in time count, and it is what it sounds like. On a single night in January, advocates and organizers go out and they count folks. And you can imagine that that is not a perfect process, but it is one we've been using consistently. And so it helps us to compare years over time here. And you can tell on this graph here, I think you can see my cursor, that homelessness was on the decline for many years. And until about 2016, it started to creep back up. And again, this is just a snapshot on any given night in January of the year, but we can see that homelessness has been rising for the last 5 consecutive years. And I just put this graph together, and I don't know if it's easy to read, but I'm just showing you here that the same data from the PIT count showing that it has been increasing, and then also what health centers have witnessed. Health centers saw 1.26 million folks in 2016, and that climbed almost to 1.5 million folks in 2019. And then it was not a decrease in homelessness that saw this decline here, but COVID, of course, decreased the amount of visits and new patients and individual patients that all health centers saw. And here I want to show you just the different shelter arrangements. You may or may not know that only healthcare for the homeless designated health centers are required to report the different shelter arrangements, whereas other health centers just are required to report the total, although all health centers can report the individual shelter arrangements. So this is just a snapshot of the 300 or so healthcare for the homeless programs and the shelter arrangements going back the 4 years, 2017 to 2020. And here the takeaway is both that homelessness has been on the rise across all categories, but also street homelessness, which is what many of us consider when we think of just the stereotypical homeless person. That is by no means the majority of the folks that healthcare for the homeless programs are seeing, and doubling up, that's couch surfing, it remains the plurality across the different years. Does that make sense? So there's a lot we could say about why homelessness is on the rise, or why the richest country on earth has homelessness to begin with. But the main point here is that affordable housing is scarce. And it may be true that there are personal factors that inhibit folks from being able to pay their rent. We know that interpersonal domestic violence is the #1 cause of homelessness for women and families. We know that the criminal justice system or the foster care system or education systems are big feeders into homelessness. But what makes somebody homeless is their lack of secure and adequate housing. It's not those other personal factors. And so we really need to be honing in on the affordable housing crisis in this country. And I would love to draw your attention to the annual report called Out of Reach by the National Low Income Housing Coalition, such incredible partners there, that talks about the housing wage. So the housing wage is what you need to earn, the hourly rate you need to earn without spending more than 30% of your income on rent to afford a modest rental apartment. And they find that in no single jurisdiction in the United States can one afford a modest 2-bedroom apartment while earning the prevailing minimum wage. And so that's the local minimum wage, not the national one. And I think it's just in 5% in all counties can you afford a 1-bedroom while earning the prevailing minimum wage. And so we talk about the fight for 15, to raise the minimum wage to $15 an hour. But we see that in the 50 local jurisdictions that have a higher minimum wage than their states, each one is lower than the housing wage for a 1-bedroom apartment. So really 15 is the floor and not the ceiling. And I want to just, another document publication to draw your attention to. Leilani Farha was a former rapporteur on the human right to adequate housing, keynoted at our conference a couple of years ago. And finally published their final report on the guidelines on the implementation on the right to adequate housing. And I mentioned in our mission statement that we are grounded in human rights. And really just succinctly saying that this is a matter of the financialization of housing, that housing has moved away from its social function to be an economic function that has become prime investment for equity firms. So again, there's so much more we could say about that, but we got to move on. You've heard of the social determinants of health. Well, I kind of want to interrogate that concept, and the paper I'm going to promote to you in a few moments. We've been using the term structural impediments to health, and I just saw a HRSA webinar advertised just 10 minutes ago or something that used, I think, structural barriers to health or social barriers to health. So I'm happy to see us start to interrogate some of these terms. But the point is that it's not the interpersonal sort of issues that the term social connotes, but they're structural issues, and they're not just happenstance. They're like the byproduct of conscious policy decisions. But in any case, if we are serious about the so-called social determinants of health, we have to target housing. Because if you just look at any of these other categories, how can we access education when we're living under a bridge? How are we going to access healthy food when we're living in a shelter? How are we going to access and afford health insurance when we're sleeping in our car? So really everything here hinges on our access to adequate housing. And so if we are serious about addressing a social determinants of health in our healthcare systems, then we really need to make sure that we're taking housing instability seriously. And I think if you think about this for any moment of time, you start to realize how straightforward this is. If you start to put yourselves in the shoes of somebody living on the streets, you can imagine how difficult it is to be healthy while you're sleeping outside when you have no access to secure and safe housing. And that's primarily because your individual daily choices to survive take a backseat to accessing healthcare. And everything is structured to inhibit you from accessing adequate healthcare services. And how are you going to adhere to treatment plans? How are you going to refrigerate your insulin when you're sleeping outside? How are you going to keep yourself safe from cold weather or storms? How are you going to access healthy food on a regular basis? God love our outreach workers, but a lot of the times the gift cards that we're handing out are to McDonald's. You know what I mean? It's still really difficult to access healthy food. Those of us who work in healthcare know how devastating sleep deprivation can be on our health, right? How are you going to get a good night's sleep when you're constantly being told to move on from your park bench? Or so many communities are making even the park benches or other areas difficult to sleep on by adding those middle armrests. And of course, COVID has exposed just how vulnerable people experiencing homelessness are to communicable diseases. We know that people without homes are much more vulnerable to violent attacks and much more likely to be the victim than the perpetrator of a violent attack. We know that the majority of people experiencing homelessness are people of color, and that compounding levels of oppression that people experience only has worse health impacts. And we also know that homelessness may be precipitated for many by medical issues in the first place, and it's still the case. This is a recent statistic, about 67% of personal bankruptcies linked to medical bills or illness. So just wanting to point out here that the folks who are experiencing housing insecurity are probably the sickest of our patients. So it's really important then to know whether they're experiencing housing insecurity. And I haven't mentioned this yet, but this is just a depiction of Maslow's hierarchy of needs, the premise of which, of course, is that you cannot really attend to these higher levels of human needs until you have met your basic physiological needs, right? And of course, shelter being one of them here, but shelter affecting access again to sleep, to clothing, to reproduction, etc. And I'm not going to spend much time on this at all, just because I want to get out of the way as quickly as possible. But the next couple of slides here just showing pick a health condition and people experiencing homelessness suffer it worse than stably housed folks. And I don't want to pretend, even though we talked about how street homelessness is by far the minority within the homeless population, that all different housing arrangements affect health equally, because we know that unsheltered folks are more likely to have worse health outcomes than other kinds of homeless experiences, like living in shelters or couch surfing. And this is a report, it may be difficult to read again, but I encourage you to dive into from the California Policy Lab that showed just how profound those differences are, folks. And especially the longer you are outside, the longer you are experiencing unsheltered homelessness, the worse your health becomes. So these are really disturbing figures, right? So here we get to the HCH gap. I researched a couple of years ago. I went through the list of the largest US cities, and I arbitrarily chose the term 100,000 or more to determine that definition of large. If we lowered it to 90 or 80, which are still pretty large cities, then of course this number would be even more drastic. But 33%, a third of large cities, don't have a healthcare for the homeless health center. And I'm calling that the healthcare for the homeless gap. We know that healthcare for the homeless programs account for just 22% of all health centers. There are about 300 healthcare for the homeless programs among 1360 something at this point, total health centers. But those programs serve 66% of all unhoused patients. We also know that in the 2020 UDS, that 39% of all those non-healthcare for the homeless health centers reported 50 or fewer unhoused patients, and 92 health centers reported 0 unhoused patients. And we think that that is probably just a matter of screening, because we know, especially given through everything I've just said about the breadth of the definition of homelessness, that all health centers are probably serving people experiencing housing insecurity. So we'd like to see that number change a little bit. And I think if you've heard Jim McCrae or many other HRSA officials say in public spaces that we do not expect new access points anytime soon. And I know that that's a congressional issue, not a HRSA issue. But no new NAPs. No NAPs means no new healthcare for the homeless programs, which means all those communities that don't have a healthcare for the homeless health center, where are they getting their services? Where are they getting their healthcare? That's the question that we're taking up today. And we just want to make sure here that you know that we're not saying healthcare for the homeless doesn't matter. It is a meaningful designation. It is the root of the healthcare for the homeless movement in the council organization. But just the main point here is that you don't need that healthcare for the homeless designation to provide HCH care. And our next two speakers are going to demonstrate that. So I'm really excited now to hand it over to Arlene Simon, who is both the COO and CIO at Alliance Community Healthcare in New Jersey. And with that, I'll hand it over to you, and you just let me know when to advance your slides, okay?
There you go. Hi everyone, and thank you very, very much, Michael. Just as a brief introduction, the reason that the first slide that you're seeing, it basically says we're looking at the unhoused / taxpayer and the descent into poor health. So my take on this is that it is a glaring failure across the board. A country that positions itself as the world leader and the greatest country in the world, and we have one of the worst unhoused population crisis anywhere in the developed nations. We basically are bordering on the verge of a country soon to emerging, into the development status. So next slide. And we're in New Jersey, and my introduction to you, as Brian states, I am the COO and CIO of Alliance Community Health Center. We're a small health center located in Jersey City, New Jersey. We're in the very, very heart of one of the most rapidly developing cities in all of the United States. There are so many cranes in the sky right now. If you come to Jersey City, I think they have to put warning signs to the planes that are going by. We have a saying here now that if you stand still for anything close past 5 seconds, they will pour concrete on you because they'll think you're a new spot to build something on. Currently, it states, and this is a number that came out of the most recent PIT study, that Jersey has approximately 9,662 patients unhoused on any given night. And I will tell you, as you all know, that that number is not close to reality. Next slide. So we took a look at this from a very broad perspective. And one of the things we looked at was, what would it cost to provide shelter? Well, the average cost to provide shelter we found was between $5,000 and $6,000 per night. per month to provide someone with a cot in a facility. The average rental in our tri-state area, and this include, I should say, the metro area, is $1,300 for a studio. That could depend. And when we thought about that, I looked at the fact that a billionaire just spent about $0.6 billion to hop on a phallic-shaped rocket to spend 3 minutes eating M&Ms above Earth in our suborbital space. They didn't even make it to space, 3 minutes. So we definitely have a disparity problem in our country that is getting really to the verge of crisis. Next slide. This is our Stepdown Unit. It is a former nursing school that belonged to Christ Hospital. And the reason I'm showing you this picture, this is going to explain how we really got further into working with an unhoused population in a more direct relational manner. This property was turned into a step-down unit by Alliance CEO, who said, when the county called and asked if we could help with homeless population in the midst of the COVID crisis that could not be sent home to shelter in place and isolate because they were not in a position to have safe housing. The nursing school was empty and not being used by the hospital except for a few offices. In conjunction with Hudson County and CarePoint Christ Hospital, we were able to have this space ready in a matter of 8 to 10 days. That ramp that you see built there, we actually had that ramp built in 2 days so that we can accept patients. Once we got the inside all cleaned up and we had beds, we realized that people would be coming over in gurneys and wheelchairs, and there was no accessible points. It's not the best picture, but there's some really stairs to climb up before you can get to the entry door. So we had that ramp built. And like I said, we had that done in 2 days. Next slide. So we got into taking care of the unhoused population and people that are experiencing what we call traumatic incidents of crisis homelessness. We just did it. There was never a mandate that came down. There was no funding. And that's the approach that we've taken to this. Our attitude is to just do it. Alliance Community Healthcare was founded in 1963. Our founding came about because 3 women got together. They eventually became like 5 women in total when there was a crisis of death by abortions that were unsafe and unhealthy. Alliance was founded by women, for women, to help women. And we have taken that and we have expanded that. We no longer are, we are now a fully funded federally qualified health centers. Obviously, back in 1963, things were very dire. We are now a full service healthcare facility. And our commitment to being a safe space for healthcare delivery is unwavering. At ACH, there is no homeless person. There is only the individual patient and their care team. Social determinants of health is not addressed as a separate issue in the delivery of healthcare, but an integral component of a person's ability to achieve a status of health and well-being. Unaddressed social determinants of health impedes the care goal of achieving a fully realized, improved health outcome. Next slide. And I continue with our Just Do It team. Alliance has worked with patients experiencing the trauma, and yes, it is a form of trauma, of being unhoused. Actually, Social Services Division and outreach teams have served thousands over the years in finding safe housing for people in domestic violence situations that could result in grievous harm to themselves and others, and vulnerable members of their family. We help a lot of women and children find safe shelter. We work with you, and we have several shelters in the area that we work with. Over the years that we have long-term partnerships with, that we care for. We care for young children who have been traumatized either by violence or sexual abuse. And we have staff that are specially trained to deal with situations such as those. We have on-site, round-the-clock, 24 hours social services available, and we make ourselves available as a safe space. We have worked with the city and county agencies to mitigate situations that would otherwise turn someone into losing shelter, utilizing home visits, providing transport to healthcare visits and supportive services, and employing numerous other supportive care tools at hand. Then along comes the pandemic, and what should be done with COVID-19 patients who cannot safely isolate in a space of their own. Alliance was called to action by the county. We were asked at the very last minute and to get a space donated by the county up and running in about 10 days. We were able to do that with about 100 beds, inclusive of isolation rooms, private bathrooms, and provide 3 meals per day, along with other resources such as new clothing, well-being supplies, in support of the transition of care and outreach teams to transition the most vulnerable to safe housing, inclusive of follow-up support from the ACH healthcare teams. Next slide. So how did we do it? It starts with recognizing and respecting the human being you're engaged with. No judging. We are all flawed. No lip service. Commit to supporting a person in partnership. Recognize the resources they have within their own capacity. Because we realize often people, when you're working with vulnerable population in supportive services, there is a misconception that people just want to be picked up and put somewhere. Most of the times when you're dealing with the individual as a human being and recognizing and respecting their dignity and their willingness, they just have not been able to see a path forward. And we start with that. So we recognize their own capacity and the process required to access taxpayer-funded supportive services within the continuum of care. And then we recognize what is within the scope of the health center. What can the health center actually do legally to mitigate the suffering? What can we get done timely? And it's what we started with. HCH provides healthcare. So that's where we started. And then we hold our partners in care, outside agencies, accountable. We set up a terms of agreement. We make the whole plan of action and agreed upon platform in which we will engage. Define roles, service capacity upfront, and target resolution and the outcome as the goal. And we do that with every agency that we work with. Next. So this is a quick flash about Stepdown Unit. This was the first day we got all the beds in and got everything up and running. And this was actually very, very well received. We ended up serving over 300 people in the first couple of, I think the first couple of weeks that came through. Overall, I believe the final number was some 789. Next. We also served families, and I did not include those numbers, but yes. So how can we help? The barriers to housing for all starts and ends with bureaucracy. And I could go on and wax poetic about bureaucracy because it is the bane of my existence. But I will say that what we have found is oftentimes it is someone did not check a box, or a box was created that had to be checked. And then from there on, it just gets, this needs to be added and this needs to be approved. And people are sitting outside in the rain and in the sun and on the bridges while we check boxes. So our approach to this was remove the communication barriers. We must plan to do better, recognize that the resources are and have always been available to house everyone. Housing resources, as we speak today in Jersey City, and we are shooting upwards and adding these multi-level luxury apartment, because everywhere you go, there's a sign that says luxury coming soon, luxury. I don't know what luxury is anymore. I guess a washer and a dryer determines luxury. Well, we all have luxury. And there's so much capacity that they forgot that there are abandoned buildings that are still sitting empty that could be quickly converted to house people and provide housing. People simply want to live with a modicum of dignity. Not everybody wants to walk into a shelter with 100 cots or 200 cots across, an armory, and that's all you have. And that's one of the things that we found with the people that we were able to serve. They all spoke about the fact that they felt respected, they felt like they were seen, and that's all we need to start with. And as I will say, I'll continue, keep it simple. This is our health center. This is the Alliance's Health Center. We are located, as I said, in the heart of downtown Jersey City. We're in the prime of all of the buildup, which doesn't help us much. And this is 115. Next slide, please. So I wrote here that the health center is not funded for homeless, and that is absolutely. We are not a designated homeless care health center. Alliance gets no federal or state homeless funding. The health center has approximately 700 individuals currently that met the determinants for being unhoused. And we know if we really dive into that, we probably have more. But these were the ones that we accounted for that our social services department is currently managing. The health center's leadership has committed to not only being a healthcare home for the unhoused, but our social determinants of health team of outreach advocates work tirelessly to find and secure stable housing for those we serve or may encounter during outreach. To date, the team has found stable housing or long-term shelter for over 120 individuals and their families who have received care during the recovery from COVID. Excuse my misspelling. Next. This I wrote as paid back and paid forward. Actually, this was about the folks that have come through the Stepdown Unit. And I state here that we continue to work let me just backtrack a bit. Because of the work that we were able to do quickly to help in COVID, Hudson County actually has a new department that they formed for housing and community reintegration, as well as working directly with the reentry program of the prison system to assist unhoused and formerly incarcerated individuals gain access to all available entitlement programs. Though Alliance was only funded by Hudson County to provide supportive medical services, the outreach and support team knew that taking advantage of the opportunity to provide care and treatment to unhoused individuals being cared for during their recovery from COVID was a golden opportunity not to be missed. The team encouraged the individuals experiencing homelessness to take advantage of finally having an address and to use it as a great opportunity to apply for and receive out-of-state birth certificate replacements, social security cards, and IDs. Our team applied for emergency cash services and ensured that individuals not only left the COVID-free, but they worked to discharge them to safe, stable housing. We actually worked with the county to get people that we could not find immediate housing for, to get them into long-term stay hotels and motels in the area, where the county worked and paid for blocks of rooms. So we transitioned some people to those, and some people we were able to get into apartments, and they were able to return to work. Many folks who have transitioned out of the facility still return to the step-down unit. They pick up their mail, they volunteer, they do outreach with the Alliance teams, handing out flyers and brochures, which is something that I still get a big kick out of. Some now have steady work and are even giving back, donating t-shirts, packs of socks and underwear that they remembered receiving upon their arrival to the unit. And it meant so much to them, for those who came next. And to that end, I will tell you, some of the folks that came in were experiencing psychotic breaks. Some were simply unable to afford rent. So we had a very diverse population. I remember one guy came in and he was covered in lice from head to toe. And we had to burn everything before he could get beyond the intake room. And luckily, the way the facility is set up, we were able to give him a shower and clean clothes. And that gentleman, who barely spoke or didn't do anything, is now one of our regular visitors who comes back. He helps, he cleans up around the facility. And I don't recognize the person that came in and the person that comes to the facility today. Next. And that is my brief and short presentation. And thank you so much for hosting me.
Thank you so much, Arlene. I hope we have time for some Q&A with you at the end here, but we're going to move down south now to hear from a non-expansion state health center who's doing the work too. So Trish, I will turn it over to you.
All right, thank you. I'll try to get through this quickly so we can have some Q&As and at the end. So my name is Trisha Eklund, and I'm the Vulnerable Population Program Coordinator for Blue Ridge Health. We were founded in 1963 as well, and we are the nation's oldest migrant health center. We are a patient-centered, oh, I'm sorry, go to the next slide. We're a patient-centered medical home for anyone in Western North Carolina. So we have 8 different sites in 8 different counties and 13 school-based health centers. We offer medical, behavioral health, dental, nutrition, and in-house pharmacy services. We are an FQHC, and we also partnered with the local hospital in 2012 and the residency practice nearby to become the first HRSA-funded teaching health center in North Carolina. We just assume sites like taking over Rome is what I've been told many times. We try to get them or try to get everyone access to care is our biggest goal. And we partnered in 2015 to assume operations of the local Good Samaritan Clinic, which was a partnership with the local Hendersonville Rescue Mission. And we started out with that with a half day a week, just doing, having one resident and one faculty staff, and it quickly grew into becoming a full functioning primary care home for many patients. And it was also uniquely located adjacent to the Outreach Day Center with the Rescue Mission. Next slide. So that clinic, or the Rescue Mission, had a clinic space that operated that clinic for several years, but it was just inconsistent with volunteers and staffing and resources. So they weren't really able to fully meet the needs of the community. And when they collaborated with us, we had the same goal of trying to provide this access of care to our most vulnerable population. So we assumed operations, and they in turn gave us the clinic space in kind, so we didn't have to have a additional cost for our rental fees or anything of that nature. We were able to use our teaching health center allocations to staff the clinic with that resident without adding additional salary costs to the site. And so we are able to use that similar model to break even on costs for a few years, because though our other sites with Blue Ridge Health are funded through our Migrant Health Center funding and mostly federal grants and donations, the 7th Avenue site was just a mission driven site. So we wanted to do it because we believed in we believe in our mission, and we were willing to eat the cost and try to break even. We can, as we were able to assist and serve the community. We utilized a salaried employee that managed both that site as well as a revenue generating site. And that salaried employee was me. So it was great to have to, while the ramp up was happening, it was a little bit hectic, but we did a ramp up and expanded to use staff from other sites to cover clinic operations as we grew, pulling them to cover rather than allocating their full salary to that one site. So that helped us manage and break, even without having to incur a lot of costs. And then we also collaborated with local partners that had received grant funding for programs. And we offered the health center as a space for them to utilize those programs. And we collaborated with them to, again, bring in more patients and provide access to care without creating more costs for us for operations. Next slide. So the vulnerable population, we've been serving the vulnerable population for years and addressing the needs of people experiencing homelessness from our fixed health center. In the last two to 3 years, we began attending the local homeless coalition meetings where we were introduced to the continuum of care and coordinated entry system. And we just started participating in that process and trying to help out by conducting paper screens and demographic updates and homeless verifications, and then of course everybody knows COVID hit like a brick, and we had to make changes. Though we were a health center, we had to pull to our bigger sites, and unfortunately we were faced with having to close our smaller sites to be able to manage. And we were suddenly faced with this urgency of trying to find funding in order to stay open, that we weren't faced with in the past. So for 5 very difficult months, I devoted all my time to researching every funding opportunity under the book. Or under the sun. I just looked every avenue, and all the while working registration, the clinic floor, patient care, doing checkouts, just so our clinic could remain open. So I have a wonderful team of doctors and community partners that, they didn't hesitate, and they jumped right in to help, because they shared this understanding that it would be a disservice if we didn't do it. We had to keep this open, and of all times, we had to keep it open now, because, people experiencing homelessness have nothing, and overnight, they already had very little, but now they had access to no facilities. If that wasn't stressful enough, similar to what Arlene was saying, we were chosen to run the FEMA shelter, the temporary FEMA shelter, for people experiencing homelessness that had nowhere to isolate. So I also did, I was the lead in providing all the clinical intake, the assessments, the discharge for the entire county during that time. So needless to say, I say great things are forged under pressure. Next slide. So as COVID exposed those gaps in our system, we've known these gaps for decades, and it just brought them to light. As Blue Ridge Health, we took on the challenge of our community. We faced it head on, and we provided mass testing, mitigation strategies, coordination, and clinical oversight of the county's temporary FEMA shelter. I've transported many COVID patients back and forth across town, and when there was a need, we just did it, and it was because we had, it wasn't because we were required to do it, it's because it was the right thing to do. And we truly saw that the value of our organization that provides to our community, and the community actually felt that value. I feel like if they really felt it during COVID, if they hadn't felt it in the past. So it helped our organization to truly understand that our mission-driven services generated value, even during the times that it didn't generate revenue. And we started looking at funding opportunities in places that we never thought about pre-COVID. Housing, we know housing is healthcare, but we never looked through the housing avenue for funding. And it opened up a completely new door, which now thinking back on it, I can't believe we never went that avenue in the past, because it just goes hand in hand. You know, housing is healthcare, and what better way to address those social barriers of health than from their primary health provider. Next slide. So, you know, I was told many times over many years that our barrier to funding was because we were not HCH designated site. So we're a migrant health funded site, but we're not homeless healthcare site. So they were rarely knew any new opportunities for access points, is what my, you know, the common response that I got. But to me, I was out here saying, yeah, we are definitely an HCH site. You know, we're operating under the same guidelines. We're providing the care while focusing all on the same quality metrics. We've been doing this for years. So to me, you know, I designate us as that, even though we don't receive funding through HRSA as HCH, but we're still doing these things not because we're required for funding, but because, you know, it's our mission to provide quality healthcare that's accessible and affordable for all. So we did this because people experiencing homelessness deserve the same standard of care as their housed, insured, stable neighbors. There should be no difference. You should make it, if you're going to make it work for your insured patients, you can make it work for people that are experiencing homelessness and lack of insurance and all the above. Next slide, please. So we were already uniquely prepared for funding requirements. And I love the fact that we did this, because we've been doing this for years and screening and getting housing status. And I've been with Blue Ridge for over 10 years now, and we've done this since day one. And it just is the right thing to do, because we can, you know, we already had a process in place to capture social determinants of health and housing status for our patients. So, you know, when someone comes in, that's what our front desk knows to ask for registration. It's just a part of their daily routine. We also have an entire section on our discount slide for potential barriers to care, as I've listed to the right here. And I also am so crucial on our providers about putting diagnosis code in for Z59.0 for homelessness, because, you know, if we can code for it, we can track it. And we all know in the medical field that that's the best way to put it on that diagnosis list. It's going to help them with housing later when you're trying to verify that, and multiple other things. Next slide. So we've been screening, like I said, for years for social barriers to health. And believe me, it didn't happen overnight that we were able to respond to those barriers. We screened for a long time before we were able to put the pieces together to actually be able to offer things in-house. So, you know, if they come in and they have a need, we try to meet that need while they're here. And if they have food insecurity, they leave with a food box or a voucher. If they have clothing insecurities, they're leaving with clothing items or vouchers to the clothing closet. We sign people up for assistance programs, for benefits. We do transport, free transit passes. We have multiple resources that we try to connect people to, if not offer them while they're in-house. And we make a plan, we have a plan in place to case manage them while they're experiencing homelessness. We know their name, we know their story before they leave our clinic. So that way they feel safe when they come back, and they know that our team is here and they understand in a non-judgmental way what they're going through. And we're trying to help decrease those barriers so they can focus on their health care. Next slide. So why do we do this? Because we're uniquely positioned to resolve barriers because of our simultaneous understanding of both the systems and of the individual's needs. It's a small, simple process to implement that can make a huge lasting impact on the lives of our patients. And because we know that no one can focus on their health and well-being until they're no longer in survival mode day to day. And because if we're able to alleviate just very basic barriers of basic needs, then people can begin making real progress towards building their lives back. And because our neighbors experiencing homelessness are not a statistic, and they are a living, breathing human that deserve a safe place to call home, just like everyone does. And my main thing has been, if the entire world can change the way it operates overnight due to this global pandemic, then we can change the way we deliver healthcare by addressing social determinants as the new normal and making sure that we're treating people as whole health and whole body people, which involves housing, social, all the determinants that are affecting their healthcare. Next slide. And here's just some resources and tips from some sites that I had gathered some information on in my email. I'm happy to answer any questions or anything later on if anyone has it.
So much, Tricia and Arlene. I really appreciate both of you. I want to make sure that we end on time, so I'm going to get through our next slides here. And both Arlene and Tricia said a few words about how they are asking about housing insecurity. I've listed on this slide a sample of others from their real life screening questions from other health centers. And the final one here is from Prepare. If you work in the health center world, you've probably heard of that. That's certainly the most popular social determinants of health screening tool. And I wanted to point out this other resource called Ask and Code that we put out, I think, in 2016. That gets into the how and the why about screening specifically, including on Z59. I'm glad you brought that up, Tricia. And here's how not to ask. I think, as we've talked about before, many who would be screened positive for housing insecurity would not attach themselves to the word homeless. And so we just really discourage, there's not one question that the council is endorsing, but there's definitely a one we're not endorsing. So I just want you to bear that in mind as you're considering this. And so I'm just going to go through these really quickly, but they're all detailed in the paper that I'm going to promote in just a second. So here's 9 things that this publication says that you can do. First, we're going to screen for everybody. We're going to consider waiving fees. It's a misconception that only healthcare for the homeless programs can waive fees for their homeless clients. And in fact, all health centers have the discretion to make that choice. We're going to train all staff so that everybody understands the structural issues that are affecting poverty and oppression and housing insecurity, because it matters to everybody. If you're not already involved in the continuum of care, or COC, that's how HUD organizes homeless services funding, and they are always looking for healthcare partners and are incentivized to do so. So that is a natural partnership for health centers. Healthcare for the homeless programs are required to provide substance use treatment services, where other health centers are not, but we think everybody should. It's becoming part of what it just means to provide quality care. We should move not just to be embracing trauma-informed care, but really trying to be trauma-informed organizations. We're going to welcome all marginalized people, especially noting that the homeless population is overrepresented by people of color, by LGBTQ plus folks, and all different structurally marginalized people. We're going to try to encourage including lived experience of homelessness in governance. The health center program is unique in that it is federally mandated to be governed by the people that we're serving. And if you're serving unhoused folks, then you should have that experience represented on your board of directors. And then you got to get outside the clinic. There's a lot of reasons why folks won't come into our physical buildings. And so we have to meet people where we are. So here's the new paper. It profiles 5 health centers, including Arlene's, but not Tricia's, because we hadn't met yet by the time that we were putting this together. It gets into the 9 concrete steps that I talked to. It sort of also reflects on themes, including how funding is considered at different health centers, and lots of concrete tips, and a really long annotated resource list that I think it should be helpful for folks. Lastly, I want to plug the National Healthcare for the Homeless Conference coming up in May in real life, fingers crossed, in the Seattle area. So I encourage everybody to be on the lookout for that. And before we conclude, I want you to complete the evaluation survey that will automatically pop up in your browser when we end the webinar. And I think that is it. Here's how you can follow us on social media. I really just want to thank Arlene and Tricia for your time. This was a lot of work putting this together, and you all have been so generous and so wise. And so I just really appreciate all the work that you're doing. We will follow up in the follow-up email. I see, Catherine, your question. We will make sure that you have the links to everything. But we will go ahead and conclude so that you have the opportunity to complete the evaluation. So thank you all. Thank you for being here.